Good evening, and welcome to our educational webinar on Lapiplasty 3D Bunion Correction. We appreciate you joining us tonight. I'm Kara Lyons. I'm the Director of Patient Outreach for Treece Medical Concepts. Treece Medical is the company who patented the Lapiplasty procedure and manufactures its instrumentation and implants. Our goal here tonight is to provide you with quality information because we know that making a surgical decision is a big decision that's not taken lightly. And we applaud you for joining us to empower yourselves with information to make the best informed treatment decision that you can. I'll get a couple quick housekeeping items out of the way so then we can get right into the presentation by our surgeon speaker tonight, who is Dr. Thomas Pignetti from the Woodlands, Texas. First of all, you've entered the webinar on mute, but you can ask questions throughout by clicking on the Questions tab in your control bar and typing them into us. We'll be answering questions sprinkled throughout the presentation, and if you're a note taker, shortly miss, we'll be offering this presentation as an archive link to refer back to that from us in a couple of days. Lastly, I know you're going to enjoy our speaker, Dr. Pignetti, but if you're attending tonight's webinar outside the Houston metropolitan area, you can also find locally trained surgeons in your area to consult with by visiting our patient website, which is alignmytoe.com. There's a prominent Find a Doctor button at the top of the homepage, and it's searchable by zip code. Okay, with all that out of the way, I'd like to introduce tonight's surgeon speaker, Dr. Thomas Pignetti. Dr. Pignetti's experience is extensive. He has over 25 years in practice in the Woodlands, and his practice is a Lapiplasty Center of Excellence. Dr. Pignetti is board certified in foot and ankle surgery, and he is a fellow of the American College of Foot and Ankle Surgeons. He earned his doctorate in podiatric medicine at the New York College of Podiatric Medicine and completed his surgical residency at Catholic Medical Centers of Brooklyn and Queens, New York. He's an active member of the American Podiatric Medical Association, as well as the Texas Podiatric Medical Association. We appreciate Dr. Pignetti volunteering his time tonight. I'll return at the end of the presentation for a question and answer segment. And now I give you Dr. Pignetti.
Well, thank you, Kara. Good evening, everyone. I want to thank you all for joining me this evening, and it's my pleasure to visit with you and share information on the Lapiplasty 3D Bunion Correction. This is a very powerful and exciting technique, and after our time together, I hope you'll come away with some useful information. During this presentation, I'm going to cover what bunions are and what causes them, how having a bunion might impact a person's life, what are the common treatment options, and of course I'll introduce the Lapiplasty procedure, explaining what makes it different from other procedures and how it works and what the expectations are with regards to results and recovery. But first, let's go over a few important background information matters here. First of all, the Lapiplasty procedure is FDA cleared since 2015, so this is not an investigational or experimental device. This is a proven technique. It's a patented procedure, and it is manufactured by Treece Medical Concepts out of Florida. Now, this technique does require advanced training, and it's not offered by all surgeons, but thankfully thousands of surgeons have been trained and patients have been treated. And as Kara mentioned earlier, you can find the names and locations and contact information on trained doctors at Treece's website at www.alignmytoe.com/doctor. And she mentioned there's a highly visible doctor finder tool that's on there where you can put your zip code in and parameters to search for a qualified surgeon. Now, this procedure is covered by most insurances and Medicare, but cost and coverage may vary, so it's always important to check with your provider because they're going to be able to give you the most current and pertinent up-to-date information. Now, as with any medical treatment, individual results can vary. There's potential risks and recovery takes time. This is the case with all surgery. In the case of Lapiplasty, potential risks include, but aren't limited to, infection, discomfort from the presence of the implant, loosening of the implant, and loss of correction with non-union or malunion. Now, non-union is basically when two bones are connected or fused together, they don't fuse as intended, or in the case of malunion, they fuse or connect in a position that was not what was originally intended. And if either of these occur, additional treatments might be needed. And it's important to know that really only a surgeon can tell if a Lapiplasty procedure is right for you. This is not something that a layperson can just kind of say, oh, this is what I need. A surgeon that is trained in this technique is really the source that you need to go to see if this particular technique is really something that is applicable to what your particular problem is. Now, the Lapiplasty 3D correction procedure is covered by one or more U.S. patents. And for information, if you'd like to learn more, you can visit www.alignmytoe.com. Okay, so here's the question. Is bunion pain affecting your quality of life? And chances are, if you're tuning into this webinar, either you or someone you know is currently being affected by a bunion or bunions. Several studies during the last decade state that as much as a quarter of the general population may have bunions, and it's estimated that as many as 200 to 300,000 bunion procedures are performed annually in the United States alone. Still, getting back to the original question, when a patient comes to my office with a bunion, they'll typically share a number of concerns that suggest their quality of life is being affected by bunions. And those of you who are listening who have a bunion know that sometimes or often it can be painful. And sometimes the pain is worsened by activity or the amount of time you spend on your feet. And other times it's aggravated by shoes. You can find that the pain limits you from participating in certain activities. For example, exercising, hiking, dancing, running, sports, list goes on. The pain can limit your ability to work. It can impair your ability to enjoy time and be active with your children and your grandchildren, and your ability to travel and enjoy life in general. And quite often you might find over time, you become more limited in the shoes that you can tolerate. Shoes that were comfortable to wear in the past are now painful on your feet. And I've had several occasions, or many occasions, where female patients will come into my office and cringe when they confess that they now have to wear sensible shoes. That last part brings me to a kind of an insidious way that bunions can affect the quality of life for those who suffer with them. Bunions and other problems and deformities that bunions can contribute to can also be a source of embarrassment to the individual. And patients will look for me for confirmation when they come in, and they say they probably have the worst or ugliest feet I've ever seen. And they'll struggle with the fact that while closed shoes can aggravate the pain they feel, more open shoes or sandals that might be more comfortable end up putting their feet on display for all to see. Now, unfortunately, this embarrassment can delay treatment, and add to this the stories and comments about how painful bunion surgery is and how long recovery is, or how so-and-so had bunion surgery and now their bunions are coming back. All this results in delayed seeking out help. Okay, well, congratulations, because you're listening to me tonight and you're going to get some valuable information that should give you hope so that you'll be able to act and take steps to put an end to this problem once and for all. So, what is a bunion and how do you know if you have one? The medical or scientific term for bunion is hallux valgus, or the even more complicated hallux abductovalgus. That first word, hallux, refers to the big toe, and the second term, valgus or abductovalgus, like I mentioned, relates to the position of the toe. Abducto means the big toes abducting or moving away from the midline of the body in a sideways direction towards the second toe, while valgus describes rotation of the big toe where its bottom starts to face the smaller toes. Anyway, what everyone notices when they look at a bunion is that it appears to be a bump sticking out the side of the foot just behind the big toe. Naturally, this typically leads to the assumption that the bunion is a bone spur or calcium deposit, and in truth, it's much, much more complicated than that. So here, you can see, we have this bump, and underneath the skin where you see a bump, there's actually an angle created by two bones that have moved out of alignment with one another. We'll show you this in more detail in just a few minutes, but if you humor me, do this for a moment. I want you to extend both of your arms out in front of you as if you were diving into a pool or like pretending you were Superman. So both arms are extended in front of you. You want to keep your head up so you can see your hands. Now imagine that this left arm is the big toe and the right arm is the second toe next to it. What I want you to do next is to kind of bend your left arm at the elbow while moving your elbow slightly out to the left so that you can point your left hand toward your right wrist. This is actually kind of what's happening under the circle here on this right foot, on the slide. The angle made by bending your elbow is like the angle formed between two bones in the foot. This angle gives the appearance of a bump, but there's really no bone spur here or growth involved, just an angle or a corner formed by the two bones and their relationship with each other. So here you can see that bunions come in all shapes and sizes from mild to wild. Generally, as they progress, not only do they worsen in severity over time, but other deformities actually start to appear. Again, as you look at these pictures, try to imagine the bunion as an angle created between two bones. One bone actually in the big toe, and another in the foot just behind it. Again, we'll show you this in a moment. So the bunion is actually a misalignment of these bones rather than a bone spur or calcium deposit. Now, basic to the understanding of why bunions can hurt is that your feet have to support your entire body weight when you take a step. Most of that weight is transferred through your big toe and the bone just behind it. And as I already mentioned, in the case of a bunion, these bones are misaligned, and the instability and the abnormal pressures associated with this misalignment is what actually leads to the pain. So, the most common complaint that patients who come into my office share with me is that their feet hurt, they're in pain. And they're experiencing some swelling at times, and often the skin around the bunion is red and warm, which are signs of inflammation. They can experience abnormal pressure or numbness, and generally symptoms get worse as the toes get more crowded, as when certain shoes such as high heels are worn, or when they have to stand for long periods of time. Again, patients will share that their shoes were comfortable in the past and they're no longer comfortable. Eventually, patients complain that the variety of shoes that can be worn without pain have become more limited over time. And patients will share, often that they've always worn good shoes and they don't understand why they're still developing bunions. Well, then what are the causes? Most importantly, people who have bunions are genetically predisposed to have them. So if you have a bunion, just like the color of your hair or your eyes, the genes leading to developing bunions was also passed down to you. You might not have to look far back to confirm that your mother or grandparent also has or had bunions. So you were genetically predisposed to developing bunions. And as you go about your business over the years, the bunion forms as a result of the biomechanical imbalance brought about by the unstable foot structure you inherited. The bones and joints shift position, and the symptoms begin to appear. Now, many times there's a misconception that wearing bad, poorly fitting, or high-heeled shoes cause bunions. And while this is not true, constrained footwear or tight footwear aggravates or accelerates the condition. This is why we tend to see many more women in the office with bunion complaints. It's not that men don't develop bunions. Our shoes are just more accommodating and don't aggravate the condition to the degree that high-heel shoes do in women. Remember, there are plenty of women out there that wear high-heeled shoes and never develop bunions, while there are men who have come into my office with some of the worst bunions I've ever seen that more than likely never have stepped into a high-heeled shoe. Let's not forget also that men are typically less likely to seek medical help, generally speaking. Women are generally more in tune with taking care of their health or tending to an illness. With men, it's often our wives or significant others that are coaxing us or actually making the appointment for us to see a physician. Now, obviously, the occupation that you have or the activities that you partake in can have an effect on the development and symptoms related to bunions. Individuals who are more active or who spend more time on their feet tend to develop more complaints or issues. And I frequently see a disproportionate number of nurses, teachers, flight attendants, and athletes with bunion complaints. individuals with these occupations and activities tend to spend a great deal of their workday or time on their feet, and the other times the required footwear for the occupation or activity is affected as well. For example, men might have to wear steel-toed shoes in the workplace, women too, but in the case of men not wearing high heels, often I'll have men that wear steel-toe shoes in their workplace, and that unyielding nature of that type of footwear will typically aggravate their bunions. And again, athletes who enjoy running and tennis, for example, just like dancers, place enormous stresses on the forefoot as well. But still, anybody can really be affected by bunions. So let's talk about shoes. So we've already established that shoes don't actually cause bunions, genetics does. And those of us who've been unfortunate enough to have been passed down the genes making us predisposed to developing bunions have been given, through no fault of our own, an inherently unstable foot type. However, as I alluded to a minute ago, shoes can have an impact. And when you're predisposed to having bunions, anything that increases the stress on your feet can cause problems with the already inherently unstable foot structure. So while increased weight, increased stressful activity, and increased time spent on your feet can all create overuse problems that aggravate or accelerate the development of bunions and bunion-related complaints, shoe selection can have similar effects. So, let's go ahead and take a look at these shoes. For example, sure, they're pretty, and I understand that women like the way they look in a pair of heels. Heck, men like the way you look in them too, let's be honest. Still, you can't deny that if you're going to spend a lot of time in shoes like this, there are going to be some consequences. There's a lot of increased pressure that's placed on the ball of the foot, particularly where a bunion can develop. The toes can get crowded together, and the big toe gets pushed towards the little toes, essentially encouraging the development of bunions in those who are predisposed to it. Now, I'm not saying that women should throw out their heels. I'm not even saying that if you have bunions that you should throw out your heels. I'm just wanting to point out that if you wear high heels every day or spend a lot of time on your feet in them, you're going to be more likely to develop problems. As with anything, moderation is the key. Also, it's important to note that if it were possible to correct an inherently unstable foot type, the foot would be less likely to be negatively impacted by the forces produced by the wearing of heels. So our goal as foot and ankle surgeons is to offer a solution that would permit the wearing of fashionable shoes in moderation. Just remember that the higher the heel and the pointier the toe, the more stress will be transferred to the feet and the toes in particular. In short, bunions and our tendency to have problems with them are due to genetics and are impacted by environment. In other words, they're the product of what we've been given and what we do with them. So all this brings up a number of questions, and you might be listening to this and wondering, am I candidate to have my bunion treated? Well, the FDA has cleared the Lapiplasty 3D bunion correction for people ages 12 and above. Now, this is not surprising because below this age, there are several structural concerns such as growth plates that are in the area being worked on, and injury to those might affect how the foot grows and develops from that point forward. So this is pretty standard and straightforward. And to date, in my practice, I've performed Lapiplasties on patients that range in age from 15 to 76. And more important than that actual number, as age increases, as with any surgery, there are increased concerns regarding overall health, circulation, and healing that affect medical and surgical risk. Again, these considerations are not limited to the Lapiplasty procedure, but all surgeries in general. So there's a question, is there ever a bunion that's so severe that it can't be treated? And in my opinion, the answer is generally no. The Lapiplasty 3D bunion correction is a very versatile and powerful procedure. I like to say that it can address bunion deformities that range from mild to wild. But one thing to consider, however, and something that I see in my practice quite often, is that we're talking about instability here that has led to a misalignment of bones and joint surfaces. Now, over time, this misalignment can cause adaptation of the joint surfaces and uneven wear of the joint cartilage, leading to arthritic changes. and we'll cover this in more detail in a few minutes. Unfortunately, when there's sufficient arthritis in the bunion joint, a Lapiplasty might not be the most appropriate solution for the problem. Fortunately, there are other options, but this is where a thorough examination by a qualified surgeon is necessary to determine the optimal procedure. So, what if I've had a bunion surgery in the past, some people ask. And patients come into my office asking this, and you yourself may be wondering, can I still have a Lapiplasty? And the answer is yes in most cases. Again, if arthritis has not yet become an issue, Lapiplasty still can be used to correct bunions when a traditional 2D procedure has failed. Some of my most satisfying cases and some of my most satisfied patients were those in which a procedure was done in the past that either failed to fully correct their bunion or initially appeared to correct the bunion, but over time the bunion returned. In all these cases, thankfully, I was able to perform a 3D correction of that bunion deformity and give the patient the desired result that will likely stand the test of time. Okay, so you might wonder, well, what if my bunion is not that bad, or if it doesn't really bother me that much or often? Well, it's important to understand that bunions are a progressive disorder. That means they get worse over time, and therefore they don't go away on their own. Left to progress on their own, the deformity will get more severe, and it'll lead to other foot problems such as arthritis or other deformities. So, based on the next question, what happens if I don't treat my bunion? What if it goes untreated? Well, as already mentioned, it can get worse, and as they do, arthritis eventually sets in. As the big toe presses up against the second toe tends to lift up over the big toe, and that's what we see over here on this picture. In an attempt to get out of the way, and this leads to what we call a crossover deformity. The toes may become curled or hammered, and when this happens, often painful skin or corns will occur on the knuckles of the toes due to them rubbing against the interior of the shoe. Bone spurs can form and the foot becomes more deformed, and there's uneven pressure on the sole of the foot, and this can lead to pain in the bottom or ball of the foot, most commonly at the base of the second toe on the underside of the foot over here. Now, conservative or non-surgical care, does have a place in all this, but it needs to be understood that conservative care functions primarily to alleviate symptoms or at best delay the eventual progression of bunions. But it doesn't correct the bunion because it fails to adequately address the root cause of the condition. In other words, you may be able to lessen the pain associated with bunions, but they'll typically worsen over time until they are properly corrected. Okay, so what are some conservative treatments? I've had patients come in for a bunion consultation all the time, and they've already tried a variety of things to treat their bunions. They've applied toe spacers, and these little gel inserts fit between the first and second toes, and they're intended to separate them. But often they tend to cause problems for the second toe, making the second toe more unstable and prone to shifting position or hammering due to the pressure from the big toe being so overpowering. Now, different types of splints or devices have been tried, but the problem with these is most of the stronger ones are actually designed to be worn when non-weight bearing or when you're off your feet. They're quite bulky. The problem is how your bones and joints are aligned can vary dramatically when you're on your feet compared to when you're off your feet. And you can do this experiment now or at home, or you can kind of try it later on. If you have a bunion, you can take your shoe off and your sock off, again, if they're on. If it doesn't look too weird where you are right now. But if you can, lift your foot up toward you and get a sense of how difficult or easy it is to pull the big toe away from your second toe. Just try to spread manually using your hand the big toe away from the second toe. Okay, you got that? Now, take that same foot and place it down on the floor and apply some pressure on it, or better yet, if you can do this safely, stand and kind of reach down carefully again and see if you can safely try to pull that big toe away from the second toe while you have weight on. Now, if you're doing that now, if you do it later, what you're going to probably see is that it's much more difficult, or sometimes even nearly impossible to do this when there's weight on the foot. And this is predominantly why splints don't tend to work. They may help stretch out some structures when non-weight bearing, and they might provide some temporary relief. but they won't be effective in bringing about any corrective structural change to the foot. Now, various inserts, even custom orthotic devices, can help redistribute pressure and limit some excessive forces on the bones and joints of the foot, but they're more accommodative in nature when it comes to bunions and don't actually correct the foot. So typically the bunion will continue to progress and worsen over time. Okay, so let's get to the meat of the presentation here. Why are you all listening to me tonight? Now, we're going to share some pictures that show what's happening beneath the skin. When we look at a bunion from above, we can see this bump at the base of the big toe. Now, in this picture, we can see that bunions are more than just a bump. They're not just an overgrowth of the bone that can just be shaved off. The bunion is actually made of two main bones, a first metatarsal bone and a proximal phalanx. Okay. The names are not so important. We can just call them a toe bone, and we'll call this one a long bone. Okay. So you can see these two bones where they meet together here, and they form an angle with one another that produces the shape of the bunion. Remember when you bent your elbow earlier before? The angle made by the toe bone and the long bone are like your elbow pointing outward. Okay. Now, what I didn't draw your attention to earlier is that when I asked you to bend your left elbow as you pointed your left hand towards your right wrist, I also told you to shift that left elbow out to the left as you bent it. Okay. So basically, you were shifting. If this was your elbow, you were shifting your elbow out. You were shifting the elbow out to the left. But what you didn't realize at the time is when you did this, you actually rotated or opened up your left shoulder joint. Okay. So that brings attention down to here. If you look at this picture, the bunion is here, where the toe bone and the long bone meet, but at the other end of the long bone, towards the middle of the foot, there's another joint. It's called the tarsometatarsal joint, or TMT. Again, the name's not important, but what is very important is that in bunions, this joint is unstable, and it's actually the source of the problem that results in the bunion deformity. So, this is a pretty complex deformity. That unstable joint in the middle of the foot allows this long bone to shift out of position, leading to a separation between it and the long bone that's next to it. And then this affects the joint further up, where the big toe moves towards the second toe, resulting in the bunion deformity. Now, also, if you look closely at this picture, you can see these two small bones that are right over here that look like little beans or peas. These are called sesamoids, and they're located underneath the long bone in the ball of the foot. They're actually associated with tendons and ligaments that run to and attach to the big toe and the ball of the foot. They're like two small little kneecaps in the ball of your foot near the big toe, and normally they're centered beneath the long bone, but as a bunion develops, they'll, along with other structures, begin to shift and rotate out of their normal position. And when this happens, the foot's no longer handling stress and pressure to the best of its ability, and problems start to occur. So balance, strength, and endurance is compromised, and your feet become painful or tired more easily. And this is why a complete correction is so important when having bunion surgery. So, what do bunions look like on an X-ray? You can see a normal foot here on the left, and a foot with a bunion on the right. On the normal foot, you can see the long bone and the toe bone are pretty much in line with one another. And if you look at the joint surface where these two bones meet, the ball and socket structure appears to line up as well. Now, these two bean-shaped or pea-shaped bones, the sesamoid bones, are now centered underneath this long bone. And you can see that the first toe and second toe are relatively parallel to one another, and the two long bones, the first metatarsal and the second metatarsal, behind the first and second toes, are relatively parallel, or at least close to one another. Now, you compare this to the X-ray of the bunion on the right. There is an angle between the long bone and the toe bone. They don't line up, and the ball and socket alignment of the joint is off as well. The sesamoid bones are off-center rather than being centered as they are on the normal foot. And you can even see one of them is actually beginning to rotate into the space between these two long bones. The big toe can be seen angling towards the second toe, where there's an obvious increase in space between these two long bones, with one bone that leads to the big toe angling away from the one that leads to the second toe. So here's something really important that was not given a lot of attention until relatively recently. Now, during my residency training back in the early 1990s, surgeons used to choose which bunion procedure would be performed which procedure would be performed on a patient, primarily based on a measurement called the intermetatarsal angle. Basically, we paid most attention to how large was the angle between this first metatarsal and the second metatarsal. Those with normal angles basically just had a bump removed, and those with a modest increase in the angle had osteotomies or bone cuts made near the bunion joint, and those with large angles had osteotomies further back in the long bone. All of these procedures were chosen based on their ability to bring the metatarsal bones closer together. Okay. In a sense, the goal was to make the foot look better on the outside, and we'll touch on this more in a moment. However, now we know and give greater importance to the realization gained by research through better imaging technique that most, as many as 80% of all bunions are misaligned actually in 3 dimensions, and that's from a study in a journal called Foot and Ankle International. Now, so let's consider the Leaning Tower of Pisa over here. We all know it. Some of you may have been fortunate enough to see it in person. And due to its unstable foundation, the tower is sinking into the earth beneath it on one side, causing the tower to lean sideways in the picture to the left. The same happens with the long first metatarsal bone. The joint at the base of the long bone is unstable, and this causes the bone to lean out or shift sideways away from the long second metatarsal bone. This is the dimension of the deformity that's most visually apparent, and it's the dimension that's used when choosing between most traditional bunion surgery options. Now, what about the second dimension? Not only does the long first bone lean sideways, but also it tends to elevate or shift up away from the ground. And when this happens, there's a transfer of pressure to the bones and to the other toes on the outside of the big toe. Okay? This is what leads to symptoms such as calluses and pain in the ball of the foot, and eventually leads to problems like hammer toes. Finally, the third dimension is the one that was previously most overlooked. Now, not only does the long bone lean sideways and elevate up, but it can also rotate. Okay? This is not always easy to see, but some of you who have bunions can look down at your foot and notice that not only does the bunion stick out on the side of the foot and the big toe crowd the second toe and the other small toes, but you can make out some rotation, and it's usually most noticeable when you look at that toenail on the big toe, and you can tell that it's rotated to the side and not actually pointing or facing straight up like on a normal toe. And what's most important about this rotation is that it tends to lead to abnormal wear and tear. Just like in the picture, when your car or truck has an alignment problem, what happens? The tires wear unevenly. There can be even deeper problems inside with the suspension. And unfortunately, with your feet, you can't just throw away badly worn tires and replace them, at least not yet. So let's take a look more detailed at traditional two-dimensional bunion surgery. Okay. Now, the simplest of bunion surgeries involves just the cutting or shaving off of a bump that's visible near the base of the big toe. Now, typically, this immediately gives the appearance that there's less of a bump present. It seems simple, but what's the problem? Very few bunions are actually due to just a bone prominence. Okay? In this case, if only the bump is removed, then the bone is still leaning all the way to the left. And the joint at the base of the big toe is still unstable, as is the base of the joint at the base of the long bone. And what good is that going to do in the long term? It's kind of like removing part of the upper outer portion of the Leaning Tower of Pisa without correcting the foundation. It's not going to do anything to prevent this from continuing to be unstable and falling over. But going back to the bunion joint over here, when a surgeon shaves off such a large percentage of bone at this joint, a lot of the cartilage may be sacrificed, and this is going to actually accelerate the start of arthritis at this joint in the future. So what else can be done? Well, after removing the bump, a surgeon can try to correct for the outward leaning position of the bone by performing a procedure called an osteotomy. Okay? An osteotomy is used in the vast majority of traditional bunion surgeries, and in this case, the osteotomy, or a cut made through the bone, was made just behind the joint. Okay? Once the cut's made all the way through the joint, the part of the bone closest to the toe, right over here, is then shifted, in this case to the right, in an attempt to close down this angle, or more accurately, close the space down between these two long bones. Now, depending how the cut's made, it can correct up to 2 dimensions of deformity, typically the sideways and maybe the elevating dimensions of the deformity. The bone is then secured in place in that new position with a screw or some other type of device. Now, unfortunately, there's some problems here when doing that. The long bone, in order to bring it closer to the second bone next to it, is now curved or crooked. You can even see this on the x-ray over here. Also, look here on the x-ray at the little kind of bean or pea-shaped bones over here, the sesamoids. They don't appear to be completely centered underneath this long bone now, as they should be. But most importantly, nothing was done to address the unstable joint at the base of the long bone. And this incomplete correction opens up the potential for failure down the road and a return of the bunion deformity. So it brings up the obvious question, why are so many bunions being fixed with osteotomies? Okay, well, look at the picture of the foot on the left over here. It looks pretty good on the outside. The toe looks straight. Okay, the shape of the foot is pretty good. But if you look on the inside, as I mentioned before, the goal with osteotomies are often focused on making the foot look better above all else. The problem is, again, 2 main issues are not addressed. The unstable joint at the base of the long bone is still unstable and present, and the third dimension of deformity, rotation, has not been addressed, and these sesamoids are not in the right place. So it's kind of like putting lipstick on a pig. Yeah, the foot looks better for now, but the underlying issues are still there. So what are the consequences of this? And here are some sobering statements. Okay, 12%, there's a 12% likelihood of recurrence if 3D deformity is not addressed. And this is from the Journal of Bone and Joint Surgery, published in 2007. 1 in 3 patients are dissatisfied after 2D bunion surgery. Again, in Foot and Ankle International, as recent as 2016, and up to 70% of osteotomy patients experience recurrence over time. Again, these are sobering statements over here. So, what do we need to do to make bunion surgery outcomes better and fix it right the first time? We need a solution that corrects in all 3 dimensions of a bunion deformity and addresses that unstable joint that is the root cause of the problem. Okay, here we go. Buckle up. Lapiplasty 3D bunion correction to the rescue. Take a look at this x-ray, and you'll notice here that all the foot bones and joints look pretty normal underneath the skin. You know, hardware down here aside. Obviously, you can tell that you weren't born with that. But overall, this meets the criteria. Pretty normal looking x-ray. All the toes are in line. The big toe lines up with the long metatarsal bone. The ball and socket relationship of the joint looks correct. And even the sesamoid bones are centered properly beneath the long bone where they're supposed to be. And then the angle between the first and second metatarsal of the 2 long bones is closed down, and the 2 are almost parallel to one another. Okay, simply put, this is how the procedure works. Rather than trying to curve the long first metatarsal bone closer to its neighbors, we're going to shift and rotate the entire bone into a normal 3D alignment. This is done using a special, specifically designed and patented instrument and patented technique developed just for this procedure. And these together restore the natural anatomy, including positioning the big toe back into position. Once the bones are returned into their normal position, low profile, meaning thin but strong titanium plates and screws designed and patented specifically for this procedure are used to permanently secure the unstable joint. Okay. Previously, the root cause of the problem. And people will typically ask, obviously, what's the consequence of fusing this joint? Will I lose motion? First of all, the joint's not like a knee or an elbow joint. It's responsible for very little motion. In fact, in the case of a bunion, the motion provided by this joint has actually been pathological or bad motion. Fusing the joint not only eliminates the bad motion, which leads to the obvious deformity, but it also has a protective effect on the first MP joint, the bunion joint, the joint at the base of the big toe, which is really much more important for activity and function. So here we are, again, with a before and after comparison of a bunion treated with Lapiplasty 3D bunion correction. So look at how the structure and alignment has been improved. The long metatarsal bones are now more parallel to one another. The bean-shaped sesamoid bones are now better centered in proper position underneath the long metatarsal bone. And the big toe is now straight at the joint with the long bone and parallel to the other toes. It just looks like a normal foot. And guess what? It functions more like a normal foot than it did before surgery. Now let's compare the x-rays of a traditional 2D cut and shift type surgery and Lapiplasty 3D bunion correction. As I pointed out in the previous image, the 2D procedure here, we now have a previously straight bone that was angling out and now have a curved and crooked bone with sesamoid bones that are still not really adequately centered beneath it. And more importantly, this unstable TMT joint is still present. Now, look at this joint over here. Just take a moment. Look at this joint and see how it angles out to the left. Compare that to the Lapiplasty x-ray, where between these plates you can see this faint white line that shows the much more horizontal position where the joint was fused. Okay? Again, which foot looks more normal? These are both post-bunion corrections. Which foot looks more normal? I think it's pretty obvious. Now, if you've been paying attention, there's been quite a bit of buzz about a minimally invasive surgery, or MIS bunion technique. By using the term minimal incision surgery, they're promoting the use of smaller incisions or openings to perform the correction. And the idea is by doing surgery through smaller incisions, there should be less pain, scarring, and a faster recovery. Now, while differences in healing time or pain are debatable, there's no question as to which result is more natural appearing over here. If you look at the x-ray on the left, the MIS procedure is simply a complete through-and-through osteotomy through the metatarsal. Then there's an aggressive shift of this entire metatarsal head towards the right with a long screw and a long pin to hold it in place while it heals. It seems like the most extreme example of prioritizing outward appearance over true correction and long-term stability. The left x-ray just kind of looks bizarre. Again, the right one looks normal. Now, this is kind of interesting. The procedure on the left is a traditional Lapidus procedure. Now, Dr. Paul Lapidus originally came up with the idea of correcting a bunion by fusing this TMT joint, that unstable joint. And he performed the first such procedure way back in 1931. Now, again, the idea of fusing the joint, the idea of fusing this joint to correct a bunion is not a new idea. Now, the Lapiplasty, however, is a quantum leap in advancement over this 1931 procedure in that it has a much more predictable result, faster recovery, and is designed to correct in all three dimensions. And therefore, the results speak for themselves. Now, again, here's a normal foot on the left, and here's a Lapiplasty 3D bunion correction foot on the right. What makes the Lapiplasty foot look so much like the normal foot? Now, come on, you should be getting good at this by now. The big toe is parallel to the second toe. Long first and second metatarsal bones are now parallel and close to one another. The big toe is in line with the long metatarsal bone behind it. The ball and socket nature of the big toe joint line up, and the bean-shaped sesamoid bones are in their normal position. So one thing that I've not mentioned until now is that when performing a Lapiplasty procedure, the vast majority of the work is performed over this TMT joint. This is where we perform the fusion. Now, earlier I said that fusing this joint to stabilize it protects the big toe joint, also called the metatarsophalangeal joint, or MTP joint. When performing Lapiplasty, there's usually a small half-inch opening that's made between the bases of the first and second toes in order to release a tight ligament area. But there's no significant disruption of the joint itself, so scar tissue formation here is pretty minimal and range of motion is preserved. In traditional bunion surgery, there's much more disruption to this MTP joint structure, and scar tissue tends to occur, and there's more risk for postoperative stiffness. So, in short, the advantages of a Lapiplasty 3D bunion correction include that it fixes the root cause, that unstable joint at the base of the first metatarsal bone, the long bone, and it's able to perform a true 3D correction that makes the foot look and function as close to normal as possible. It also permits a patient to get back on their feet quickly in a walking boot, which has several advantages, including reduced time off of work and less need for help with day-to-day activities. And most importantly, it permanently secures the unstable TMT joint, reducing the chance for the bunion coming back after correction. Again, this is a proven procedure backed up by several scientific studies, including a recent one in Foot and Ankle International, again, a premier international orthopedic scientific journal, in which a 97% success rate in maintaining 3D correction was confirmed in a 13-month-long study. Again, a 97% success rate. So let's take a moment now and look at some clinical before and after photos. There's a before surgery on the left and an after Lapiplasty surgery on the right. Aside from the bump at the base of the big toe, look at the position of the big toenail itself. And you can see, obviously, the bump is tremendously reduced. The foot is narrower. But look here again, the toe. I was saying before, there's 3D rotation. The toe is rotated a little bit here. Now the nail is straight up and down. 3D correction has been achieved here. Another before and after picture. Look at the alignment. Here you can see surgical scars are fading here. There's still some mild residual swelling at 12 weeks post-op right over here. But again, look at the correction of the deformity. Here you can see the three sites where the opening in the skin are made. Okay, the largest here is where the correction mostly is made, where most of the work is, where the bone manipulation is performed, and the plates and screws are used to secure that unstable joint. This very, very small one here is where part of the positioning instrument used to shift and rotate the long metatarsal bone in place is inserted. And this one over here is the one where the tight ligament tissue that I mentioned before is released. Again, look at the correction over here. Look at the space between the first and second toes, the reduction of the prominence of the bunion here, and even some rotation correction over here at the big toe itself. Again, this one at 16 weeks. Okay, so how about recovery? What about getting back to the activities that you enjoy? Now, one huge advantage associated with the Lapiplasty 3D bunion correction is the ability to bear weight on the surgical foot relatively early during the healing process. Now, what makes this possible? Let's talk about these plates, okay? There are two small plates which are specifically designed for this part of the body to be both strong and secure enough to withstand the stresses of early weight bearing, yet small and low profile or thin enough to be non-intrusive and therefore unlikely to require removal in the future. And it's also been proven that two small plates are better than one in this application. So, practically speaking, what can you expect when having the Lapiplasty 3D bunion correction? So, unlike other similar procedures like the traditional Lapidus bunionectomy, which requires 6 to 8 weeks of complete non-weight bearing, meaning no weight at all on the foot for all that time, Lapiplasty patients can begin to put some weight on their foot within a few days. Now, there's some variability between surgeons. Some surgeons allow patients to bear weight on the day of surgery, while others or request that patients keep weight off the foot for a week or two. Now, in my practice, I keep my patients non-weight bearing for the first 3 days. I perform most of my surgeries on Friday and ask that they keep weight off their feet until I see them the following Monday in my office. Now, patients will typically use crutches or a walker to assist with this. Some will borrow a knee walker or a knee scooter for the weekend, particularly if they know someone that can lend them one. Again, they'll probably only need it for 3 days. Now, patients should expect that once being cleared to bear weight on their feet, they'll typically walk using a surgical boot or a cam walker until about 4 to 6 weeks after surgery. While the plates can withstand weight bearing in the boot, they may not be strong enough to take significant weight bearing without the additional support of the boot until that fusion is more solid. So that's why we use the boot. Now, at 6 or 8 weeks, patients typically transition from walking in the boot to a conventional comfortable shoe, such as an athletic shoe. And at 4 to 6 months, we typically clear patients for most activities. They can resume most activities, and a full variety of normal shoes can be worn as tolerated. Okay, so let's get a little bit specific over here. Day 1 to 5, your recovery begins. Now, patients have their surgery, and we send them home. I send my patients home with instructions to take a certain amount of ibuprofen and Tylenol regularly around the clock to help keep them comfortable. And in the end, it helps reduce their reliance on narcotic pain medications. But we do give them a prescription for some pain medication, prescription pain medications, should that be needed as well. Now, again, I'm keeping my patients non-weight bearing until 3 days postoperatively, and once they come into the office, we fit them with a boot, and that's where they begin to bear weight, okay? Now, there's some surgeon variation with this, but for the most part, most surgeons request that the bandage that's placed on the foot at the time of surgery is left alone and kept clean and dry. Don't remove it. When you come into the office, that first visit, that's when the bandage gets changed. A priority is placed on elevation and rest with ice application. Again, the goal is to keep you comfortable and to keep swelling under control. Foot surgery and Lapiplasty can swell postoperatively, and you're going to be a lot more comfortable if you can control that swelling, and elevation helps with that. Now, aspirin is not something uniform, but lots of surgeons recommend it because during the period that you're relatively immobile or even non-weight bearing, there may be increased chances for things or complications like blood clots, and aspirin can help reduce the tendency or risk of that. Now, again, at that first post-op visit in my office, in 3 days, some surgeons, depending on how their practice is located and how they work things, maybe a week later. Again, at that time, dressings are removed. Is the big reveal. And again, I will place patients in a boot at that time, and they are then permitted to begin walking in it. Now, it's normal to have quite a bit of bruising and swelling. We're still going to recommend rest and ice. And again, surgeon preference, if you're allowed to get your foot wet, you may be able to wash and clean the foot at that time. I typically put another bandage on and ask my patients to leave that alone. So they'll still be taking showers, using a bag or some other type of device to prevent their foot from getting wet while they're seated in the shower, washing up. You may be given some exercises just to move the big toe and to prevent it from getting too stiff through non-motion for several days in a row. Now, at 2.5 weeks, we're making quite a bit of progress here, so feeling like you're becoming you again. Typically, by this point in time, stitches are removed. I remove stitches or sutures at roughly 12 to 14 days post-operatively, and at that point, I'll allow patients to begin washing their foot. Now, it's not unusual still at this point, and even for some period in the future, to still have swelling and some tingling of the foot, okay? But again, you're walking in the boot, but you're walking in moderation. This is not like nothing happened at this point in time. You still need to listen to your body and keep things under control, okay? And again, we're continuing exercise. You want to keep that big toe mobile and preventing joints from stiffening up. Now, at 6 weeks, this is a pretty critical time. We call it early graduation. Typically, an X-ray is taken. If things look good, we will allow you to remove your boot and return to a conventional shoe. Typically, that's going to be an athletic shoe. In some cases, we may allow a very supportive protective sandal that has a heel strap to it, okay? There's mention of driving over here. Let me come back to that in a second. At this point, again, you've been able to get the foot wet, but typically at this point, it's safe to stand while showering. You have enough strength and balance and control that that's safe to do. Again, you may still find situations where you still have to elevate after a lot of activity, give it some rest, and ice it down. Typically, if patients have been taking aspirin, they can discontinue it at this time because we have much more normal muscle function and calf motion. And we allow light impact exercise. Light impact exercising meaning non-impact, non-high impact, not running, not jumping, not tennis, not high impact cardio, but walking, elliptical, things like that they can be done. Obviously, always ask your surgeon if you've got questions as far as what are the activities that you would like to do and that the surgeon is comfortable with allowing you to do. Coming back to driving over here, this is another point that differs a little bit according to surgeon preference. Many Lapiplasty surgeons will say if you're having surgery done on your right foot, you're going to be in a boot for 6 weeks, and therefore you cannot drive. It is not safe to drive in the boot, and I totally agree with that. However, in my practice, after a couple of weeks, after 2 weeks, after suture removal, and if patients are doing well, and if they're not taking pain medication, I will let my patients drive, but they're not going to drive in a boot because typically my patients, when they're discharged at the time of surgery, they're not discharged in the boot, but they're discharged with a little surgical shoe or a sandal. And this sandal is what keeps their foot semi-protected over the weekend and becomes eventually their driving shoe. So it's kind of cumbersome, but I will have my patients walk out to their vehicle with their boot on, sit down in their vehicle, take off their boot, put their surgical shoe, their surgical sandal on, place the boot somewhere it's accessible, drive using their sandal, obviously leaving longer following distances to be safe. And when they get to their location, they're going to remove the surgical shoe, place the boot back on their foot before they leave the vehicle to do what they're doing. It's cumbersome, but at least I let them drive, and my patients have done well with that. But again, follow the instructions of your surgeon because we all have our rationales and reasons why we allow patients or don't allow our patients to do different things. Now, at 12 weeks, major graduation day, okay, graduation day part 2, increase activity. And we increase activity essentially kind of, almost as tolerated. We're still going to be careful about different things. We'll let you get in any comfortable shoe at this point in time. If you've been wearing orthotics, we allow you to wear the orthotics, typically swelling down enough that you can fit them back in the shoes. In some cases, if there are other issues that have been going on the foot, we may take impressions or cast or molds for orthotic devices at this time. Patients are allowed to soak the foot. I actually like my patients to soak their foot earlier before this. Again, surgeon preference, and they can swim. Again, swelling can still be present at 12 weeks, so elevate when possible, and if necessary, use ice and rest. Now, 4 months, this is really the big deal. Now, are we done yet? Okay. At this point, we're really, in most cases, releasing our patients from all restrictions. You can return to full activity and do whatever you want to do, provided it's comfortable and reasonable for you to do so. Okay. The rest of your body might not be ready to do everything that you want to do, even though we may be telling you that your foot is ready, so you have to be careful and use common sense. At this point, we're okay with you pretty much being unrestricted and walking barefoot. We're assuming at this point, we're confirming via x-rays that the fusion site, that the bone is completely healed, okay? Now, if people are still experiencing some residual swelling at this point, and it's not unusual, compression socks can be helpful for that. I even actually have my patients, if they can wear compression socks earlier, wear them earlier, provided that they're not too uncomfortable to place on and remove. And at this point, we're essentially turning our patients loose and saying that they can call and return if they've got any concerns. Again, graduation day. Okay, so how about some frequently asked questions over here? Very often the natural is, when can I expect to return to work? Now, obviously, that answer is going to be affected by the occupation. My overall preference is that patients are off work for at least 2 weeks. Even if they have a sedentary job, they'll be more likely to rest and be more successful in limiting or reducing their swelling if they make healing their first priority during that time. Now, obviously, if your job requires a lot of time on your feet, manual labor, or being in an environment where a surgical boot can't be worn, you may need to be out for at least 6 or 8 weeks, okay? It's very important for your surgeon to understand, what your work requirements or situations are so that they can give you proper advice on how long you can expect to be out of work. And again, that's fair for your employer as well. Now, I've already mentioned before that, I let my patients drive as early as 2 weeks post-operatively, where other surgeons may keep patients away from driving for 6 weeks. Now, I kind of alluded to before, but let me just kind of restate again. I let my patient drive at 2 weeks post-op with the following conditions. They're no longer taking narcotic pain medications. Ideally, they should be driving for less than 30 minutes at a time. Again, they're going to use their surgical shoe for driving, and that they practice driving with that surgical shoe in an empty parking lot or someplace safe before actually hitting the road. And leave long following distance, as I mentioned before, to minimize short stops. Now, the foot in the surgical shoe is usually protective enough to withstand an abrupt firm press on the brake pedal, but there's likely to be some pain that surpasses what the driver is used to and may cause the driver to let off the brake pedal, possibly leading to an accident. So obviously you want to avoid that. Another question that can be asked is it possible to have both feet treated at once? And I'm aware that this has been done on some rare occasions, but I have never done it, and I would advise against it. Practically speaking, it's difficult to walk in 2 boots. And when you think about it, you can't really favor one foot without making it significantly more difficult on the other foot. Okay, so as a reminder here, this procedure is an advanced surgical procedure that requires specific training to perform properly. And you can find a trained surgeon using the doctor finder function by visiting alignmytoe.com and entering your zip code in that search engine, and a list of the nearest surgeons trained in the technique will come up. My practice is located in the Woodlands, Texas, and in a suburb about an hour north of downtown Houston, and less than a half hour from Bush Intercontinental Airport, or IAH. We've had patients drive or flying for surgery from other cities, states, and even countries, so that we can guide you in making necessary arrangements to come to town for a procedure, if that's your preference. Either way, okay, it's important to remember with this procedure, this is a serious procedure, and with any medical treatment, individual results can vary. There are potential risks, and recovery takes time. Everybody's a little bit different. Potential risks include, but are not limited to, infection, discomfort from the presence of the implant, loosening of the implant, and loss of correction with non-union or malunion. Again, non-union meaning that the bones don't heal together, or malunion that they heal in a position that's other than what was originally intended. And again, if either of these occur, additional treatments may be needed. Again, the Align My Toe website. Remember, doctors that perform the Lapiplasty have had to have specific training in this technique. Only Lapiplasty surgeons can do Lapiplasties, and only Lapiplasty is Lapiplasty. There's differences between the various procedures. So either way, I just want to say at this point, before I open it up for questions here, this has been a great procedure that has revolutionized how bunion surgery is done, and I can't express how much it's completely changed how I approach correcting this problem. If you have a bunion and you're ready to have it corrected, there's no other procedure, in my opinion, that covers all the bases as well as the Lapiplasty 3D bunion correction. The procedure is powerful, it's versatile, it's reliable, and it allows for an accelerated recovery and long-term stability with a low recurrence rate that's really tough to beat. And with that, let's see if we've got any questions.
Thank you very much, Dr. Pignetti. I found that very informative. I hope everybody else did too. I thought you did a great job explaining things. We have had some questions come in this evening. There's been good audience participation. We encourage everybody to stick with us. We'll do our best to answer most, if not all of them, now. And if you haven't yet submitted a question, as a reminder, you can do so by clicking on the Questions tab in your control bar and typing them in to us. I'm actually going to field one of the first questions myself, Dr. Pignetti, if you don't mind, before I throw it over to you. We've got, this question has come in several times, and the question is the Lapiplasty procedure covered by insurance and or Medicare? And the answer is yes. When the procedure is deemed medically necessary, insurance and Medicare typically cover bunionectomy and joint fusion procedures that utilize the Lapiplasty system. So if your doctor determines that the Lapiplasty procedure is right for you, he or she will reach out to your insurer to determine your specific level of coverage. Okay, with that said, we have some very specific questions that have been written in, really kind of giving a peek behind the scenes into people's real lives. Someone works with heavy luggage, and at times the bags on the airline can fall right onto their bunion. And their concern is what would happen if they had the bunion corrected by Lapiplasty and that still happened? Would that undo the surgery? Would it be extremely painful? Can you give an opinion on that?
Sure. My initial reaction was ouch. With regards to having a procedure, and I guess what's being asked here is the vulnerability of the foot after that procedure. I would say that particularly with the Lapiplasty procedure, what's being done is, for the most part, that TNT joint, that joint that's further back in the foot, let me see if I can go over here. That joint further back in the foot is what's being fused. I'm sorry, bear with me here. And once that joint is fused, it's really as strong as a bone that has never had surgery on it before. This whole construct is essentially one bone. If an object was to fall on the foot, it's really no different than if an object fell on the foot before the surgery. So there's not an inherent weakness afterwards. Obviously, if there's concern that something's happened, you should obviously get it checked out by your physician to make sure everything's okay. But there's not an inherently greater weakness of the foot after the procedure.
Okay. Another question has come in. Have you seen bunions affect knees, hips, or the back as a result of the patient alternating their gait to compensate for pain?
Absolutely. If you kind of use the analogy of the foundation, if the slab of your house or the foundation of your house is not even, you're going to find things like the windows don't open and close, the door doesn't open and close right, the wallpaper doesn't line up right. So with a bunion, there's, again, instability of this TNT joint, keeping it on this page over here, and that instability is like a foundation that rocks back and forth. If we kind of look at ourselves like little stick figures, if the foot's going to rotate in or pronate in or collapse inward, the leg is going to follow with that, and that's going to place sideways stress on the knee, potentially the hip or the low back. Now, I'm not a knee specialist, a back specialist, or hip specialist, but it's safe to say that problems with the foundation, of which having a bunion is a problem with your foundation, it can certainly lead to problems with joints higher up.
Okay. Are there examples of specific shoes that people can wear once fully healed?
So once fully healed, it's highly variable. We would like to say that you should be able to wear any shoe that you want to wear, ideally. Obviously within reason. Anything that would be recommended for normal foot. Obviously, there can be other problems that a patient has going on. It may be inadvisable to wear those 5-inch pumps, but it's always about transitioning into regular footwear. We go from our boot typically to a sneaker or sandal, and the reason is those particular shoes are just more accommodating. They're softer, but they give control, and they allow for swelling. Once swelling goes down, I let my patients try whatever shoe they can get in, and provided their range of motions are good, and different patients normally have different ranges of motion, I will let patients wear heels afterwards. As I said before, kind of in moderation. Eventually, if you keep trying to fit a square peg into a triangular hole, it can do damage. If not necessarily making a bunion come back, you can still do toe damage that way. So one has to use common sense, but I don't necessarily restrict specific shoes, but initially I think it bears mentioning that you need to have, well, one needs to have normal expectations, starting off with obviously not high heels, not constrictive shoes. It's all about the swelling really in the beginning. If we have good range of motion, once the swelling goes down, then I'll let patients wear whatever shoes that they choose to wear to the point of their comfort.
Okay. We have some questions that have come in Spanish, so I'm curious, does your office accommodate Spanish speakers?
I'm sorry, could you say that one more time, please?
Does your office accommodate Spanish speakers? We've had some questions that have come in Spanish.
Yes, we do. We have, at our practice, we have both Spanish-speaking staff and a Spanish-speaking doctor, Dr. Fernandez. So we do treat and are able to accommodate Spanish-speaking patient without any difficulty.
Okay. This person is likely to be flying 5 hours, 12 weeks after surgery. Any tips for that flight?
Okay, so 12 weeks after surgery, so at that point we're out of our boot for a while. 5 hours is not 13 hours, but it is a pretty long flight, and that patient will want to follow normal good instructions, just like any that you read in the information brochure on the seat back in front of you. You're going to want to periodically get up, walk around a little bit to keep blood flowing through the legs. It would be a smart idea to wear some type of compression sock to help keep swelling under control. Airline seats are not particularly spacious, and that can be all kind of constricted for blood flow in a foot that still may be prone to having some swelling at that point in time. So compression socks will help keep the swelling in check. Doing up and down flexing motions of the ankle help keep the blood flowing, and obviously getting up, walking around is a smart thing to do. And that is, in my opinion, the kind of reasonable steps to take. There may be some additional things that could be done depending on that particular patient's history and how their recovery is going also too, and that's something that can be discussed with the surgeon.
This person writes in, I was recently diagnosed with Parkinson's. It is imperative to move daily. I take boxing and ride exercise bikes daily. I have a horribly painful bunion. Could I still be a candidate?
Okay, so I wonder if that's someone in my area. I have a family member with Parkinson's that does a program called Rock Steady Boxing. Shout out to them. Great for Parkinson's. So this procedure does allow people to bear weight immediately. Obviously, there's going to have to be a little bit of extra care and guidance with the motion initially. We can still allow patients to weight bear and to use devices, let's say like a walker, even after they're in their boot, to still stay safe, but still ambulatory afterwards. Parkinson's in and of itself would not be a contraindication to the procedure. Obviously, we have to look at total health and the other risks, but there are ways to accommodate a patient with Parkinson's to make sure that we can still keep them safe through the recovery.
And just to clarify one point, when you're talking about immediate weight bearing, is that like in a normal shoe, or is that the protected boot that you were talking about earlier?
No. Oh, it's absolutely in a boot. Again, every patient is going to have to be in a boot. In my office until 6 weeks earliest. So again, typically the patient will be non-weight bearing over the weekend, and then we will fit them with the boot at their 3-day post-op visit. And at that point, if a patient has Parkinson's, we'll recommend that they use a standard walker or rollator type device just for additional stability to reduce the tendency for falls, because the boot is, while it's very protective and necessary, it is cumbersome sometimes to walk. And there's other little hints and tidbits and things that we can do to decrease the challenges with walking also too.
Okay. Well, unfortunately, I'm scanning through this and I'm seeing this question several times. People that have had previous traditional 2D bunion surgery that are not happy with the results, and they are curious, would they possibly be a candidate for Lapiplasty to revise those surgeries?
So that's a great question. I kind of alluded to it earlier that I've done I've performed several Lapiplasty 3D bunion corrections on patients that have had prior 2D bunionectomies, and I'll admit one of them was one of my own patients also too, one of my earliest patients, and they have without exception done very well and are some of my happiest patients. And these are patients that in some cases are older patients, more sedentary patients, and I have some patients that we did this procedure on that are very young and very active athletic patients as well. And what's nice about them, they really were able to appreciate kind of the difference of this procedure in terms of what they ended up with, even immediately. But they're really going to be happy when they see, how it holds up over time. But certainly, the only disclaimer I would make is sometimes after 2D bunion surgery, there may be arthritic complications that come up. If there's an arthritic component, then Lapiplasty may not be the procedure for them. I typically will do a procedure called an arthrodesis, which is scary as it sounds, is fusing the big toe bone to the bone behind it. The bunion area actually gets fused. As bad as that sounds, people can still be very, very active with that. People can actually even run on that procedure afterwards. There are shoe restrictions, obviously, that occur with it. But again, 2D procedures can be revised with Lapiplasty, provided that there isn't significant arthritis in that big toe joint, in the bunion joint.
Oh, that's ironic. The next question that we have is someone who has arthritis. It says, does arthritis in the unstable joint rule this procedure out?
Okay, so if we're talking about arthritis in the unstable joint, actually not at all. Lapiplasty is a great procedure for that because sometimes the deformities that are going on are, again, in large part due to instability in this joint. That instability has progressed long enough that it is arthritic in that particular patient. There are times that even if a patient doesn't have a bunion, the treatment for it is to fuse that joint. So that's certainly stated as is arthritis in the TMT joint or the unstable joint over here. Is that a reason not to do a Lapiplasty? Absolutely not. A Lapiplasty is actually a great procedure for that problem.
Okay. This person asks, do you break the bone to move it during the procedure?
Yeah, this comes to one of my little pet peeves, breaking the bone. I kind of get this picture of using a sledgehammer against it. When we move the bone, what we do is we release the tissues around that unstable joint, and we apply that instrument. Let's see if I can kind of quickly make my way over to it. I think I went too far. Sorry about that. Thanks for bearing with me. Here's our pig. Oh, there we go. Okay, so, whoops. Better in the foot than with this technology over here, obviously. Okay, so this device here, it's called a metatarsal positioner. What's happened first is we release all the tissues around this joint. That allows us to utilize this instrument to close down the angle and position the bone in the right position. This is really, it didn't come up in the presentation, but one of the beautiful things about this procedure is that the technique is designed to take a lot of the guesswork out. Typically when these fusions were done in the past, not in Lapiplasty form, surgeons would kind of look at kind of how they wanted the bone to end up after the procedure, and they would cut wedges of bone out, freehanding it, basically eyeballing it. What the Lapiplasty does is before we cut anything in terms of bone, we utilize this instrument to actually rotate and pivot the bone back in place. So we can actually see this is exactly how we want the bone to end up at the end of our procedure. We've not done anything permanent yet at this point in the procedure. There's then other instrumentation that's not shown here that gets placed over that unstable joint. And there are little slots in that instrument that allows us to make the cuts very precisely and very predictably, where we remove just little slivers of bone that include the cartilage on either side of that joint. And it's once that cartilage is removed that we can then secure these two bones together and apply our hardware, our fixation, our plates and screws, permanently sealing it in that place. So the bone is cut just at the edges, very small amounts, just at the edges on either side of what was the previous joint. This is no longer a joint. These two bones are now one bone once all the healing has occurred.
Okay. This question is the procedure done under local or general anesthesia?
Okay, so I would suppose this is somewhat surgeon preference. I will tell you what I do in my practice. We perform this procedure under general anesthesia. So you're under for that particular procedure. The areas that we work on have lots of little nerves that cover those particular areas, and as we manipulate the foot for the procedure, having all the muscles relaxed makes it easier to move everything in proper position. And one thing that happens when you're under general anesthesia as opposed to local anesthesia is that the muscles move, and that kind of makes it easier for me to get the correction that I need. So my procedures are all done under general anesthesia.
I guess this is somewhat related. Are they done as an outpatient procedure typically?
So all of my Lapiplasty procedures have been done as outpatients. The only reason I would imagine that someone might have an inpatient procedure would be for some other medical reason that required very close monitoring. But in my opinion, this is an outpatient procedure. Everyone that I've ever done has been an outpatient procedure.
Okay. So this person is a flight attendant. How long after surgery for a flight attendant to return to work, knowing that they'll be on their feet a lot?
So, yeah, excellent question. We see lots of flight attendants being in Houston, a major United hub. So with the flight attendant, the demands on that job are pretty significant. There's lots of time spent standing. And I'm obviously the person asking this question knows this. I'm stating it so that it would be more relevant to other people that might find similar questions coming up in their minds. So in the case of a flight attendant, there's a demand of what they have to do in their job as far as being standing most of the time, unstable surface, turbulence, having to set brakes on their cart, which requires a certain amount of leverage in particular motion. They have to be ready, most importantly, to act in an emergency situation and be able to assist the passengers safely out of the plane or to do whatever needs to be done. There's no way that a flight attendant is going to be allowed to go back to work with a boot on their foot. So typically when I have patients get out of their boot at 6 weeks, I have them just getting used to conventional shoes at a period for at least the first 2 weeks doing activities of daily living. I would say it's reasonable for a flight attendant, and this is what's been my experience so far, following a Lapiplasty procedure, I would give the expectation that they're not going to be able to perform their regular duties until a period approaching about 3 months post-operatively. And that seems like a long time, but that is a job that has some very unique requirements in terms of footwear, activities, safety. It's a particularly challenging work environment. So 3 months would be kind of what I would suggest to be a reasonable expectation.
This question is about getting both feet done at the same time. Would you recommend that? And if not, how much time would you recommend between the two surgeries?
Okay, so for the first part of that question, unfortunately, listeners couldn't see me shudder. But yeah, so obviously I said before, I do not recommend doing these at the same time. I'm aware that it's been done in some cases. I just don't think it's worth it. This is a serious procedure. You want it to heal the right way. You cannot make it easier on one foot without making it more difficult on the other foot, and it can't be good for your back walking around in two boots. So the second question is probably the more important one, and that is how far between procedures. So I have done them as soon as 1 month after getting out of a boot. So if I'm getting a patient out of a boot at 6 weeks, then we would say basically 2.5 months. Now, that's what my experience has been so far. In a patient that has a lot of freedom to take it easy, that doesn't have a job that's demanding or has a pretty sedentary lifestyle, my technical response or my official response would be, if everything went well with the patient's first surgery and they did well with swelling, they did well with their pain management, they just kind of breezed through the recovery. In an ideal, perfect scenario, the earliest that after the first procedure that I would do a second procedure would be at 8 weeks. And the reason for that, the rationale for that is, again, what I said before, in a boot for 6 weeks, get used to being out of the boot for 2 weeks before you do anything that's going to be somewhat strenuous, including having surgery on the other foot. So in the right patient, I may do them as quickly as 8 weeks apart. I will do the quickest I've done them is 2.5 months apart. In terms of my experience, that's the most the shortest time in between that I have done, actually. And my answer to the person is, you go through the procedure one time and you see what your experience is, and other than what the surgeon feels comfortable with, you take care of the second foot when you're prepared to deal with the second foot based on your previous experience.
Okay. If someone has rheumatoid arthritis, could they still be a candidate?
So rheumatoid arthritis, there's lots of variables on that one. That's a hard one to answer. Fusion procedures can be done with rheumatoid, and Lapiplasty is a fusion type procedure. But there's lots of other things going on. Rheumatoid arthritis quite often will affect the bunion joint, the big toe joint. We've said from the very start that, not from the very start, but I've said a couple of times already that if there's arthritis involved in that big toe joint, the bunion, where the bunion is, then Lapiplasty is not the right procedure for that patient. Rheumatoid arthritis is a complex condition. There's just a number of things to consider with that particular diagnosis. And I wouldn't rule it out, but I think it's something that needs careful examination and thorough discussion with the surgeon.
This person has a hobby of dancing. They say, will I be able to go back to dancing afterwards, or will my gait and balance be changed?
So obviously dancers have a tremendous need for range of motion. I do have experience in that particular area, and let's just say that the goal with Lapiplasty is that a dancer, someone that enjoys dancing as a hobby, or someone that enjoys dancing as more than just a hobby, should be able to have this procedure and continue that activity. Obviously, we're going to have much higher standards in terms of range of motion as far as what we would expect and how we want to handle that patient postoperatively. A dancer, particularly someone doing ballroom dancing that requires more use of heels and more constrained footwear and more range of motion, we will probably make more use of formal physical therapy in that patient than a person that is not participating in those activities.
I know that you mentioned that sometimes people fly in to see you. If somebody is going to schedule an appointment with a doctor that's not in their local area, how are post-op follow-up visits handled?
So post-op, some of it depends on kind of the patient's capabilities. Usually the things that we want to have a strong handle on is, I always ask that I would like my patients to be accessible to me, certainly for their 3-day post-op visit, their 12-day suture removal visit. I am willing to work with patients ordering or having x-rays performed at the patient's home city or place of origin at their 6-week x-ray visit. Obviously, we have to be in close contact if there's any concerns. Thankfully, there is technology that we can look at things over distance, but it's important. I feel that I want to have that access to that patient for a 2-week period. Woodlands is a nice area. We can have you enjoy things while you're in town visiting us.
Well, another question is about toenail fungus. If somebody has toenail fungus, should it be treated before the surgery?
Well, that's a good question. There's steps that we can take to, if it's toenail fungus and just toenail fungus, any infection being out of there is good. But, will I not do bunion surgery if someone has toenail fungus? No. There's ways that we can protect against contamination, particularly with Lapiplasty. Most of the work is done in such a manner that we can avoid contamination that way. Now, if someone has toenail fungus and they've got, in conjunction with toenail fungus, an athlete's foot infection and rash that's going and encroaching in the areas where incisions are, then that needs to be brought under control. Unfortunately, that doesn't take as long to resolve as toenail fungus.
This person has a question about microbunion surgery with tiny incisions. How is this different? How is Lapiplasty different than microbunion surgery?
Okay, so the obviously, Lapiplasty is not a microbunion surgery. Micro or minimal incision or MIS type surgery, again, is a procedure where the goal is to do all the work through the smallest possible incision. So there's lots of different ways, I should say lots of, there's various different ways of doing that procedure. These are all typically either just bump removal or osteotomy procedures. Those are the limitations, at least right now, with those particular procedures. So I would say when you're talking about a microsurgery, you're going to be talking about, in the vast majority of cases, a 2D procedure. Technically, it may be possible to do a 3D procedure with micro, but it's extremely unreliable. You just don't have the control with that technique because you don't see exactly what you're doing. It's done strictly with x-rays and via feel. There is no microsurgery currently that stabilizes the TMT joint. So there's nothing that takes care of in the microsurgery technique that I'm aware of that takes care of the instability at this first TMT joint. So microsurgery, again, is designed to try to have the procedure be less invasive by making smaller incisions, make the foot look better from the outside without having to make as large openings or scars. But again, it falls short in that they're not really correcting underlying deformity. They're, again, trying to make the foot look better by using smaller incisions to move it. So Lapiplasty just really addresses the underlying deformity and the instability and is much, much more powerful in properly correcting the foot and having that correction maintained long term.
Okay. I'm going to give you one more question here, Dr. Pignetti, and then we'll start to wrap up. Does arthritis on the top of the foot rule the procedure out?
So arthritis on the top of the foot, depending on where it is, it's certainly, I would say initially that it doesn't rule the procedure out. The arthritis on the top of the foot, I'm assuming that means like up in the instep or the top of the foot, like on top of the arch. That's similar to, those are typically arthritis that's in the other TMT joints going towards the second and third and fourth toes, usually the second and third. It certainly doesn't rule that procedure out. And interestingly enough, when a patient has a bunion, and it's because of this TMT joint is unstable, if this TMT joint is unstable, this bone's not taking its fair share of pressure, and instead all the joints here are taking more pressure and jamming at these joints because this one's not doing its job, ends up actually making the arthritis occur here, typically. I mean, if someone has a very bad bunion and they've got arthritis here, it's probably pretty likely that that bunion had a lot to do with the formation of that arthritis. So correcting the bunion via a Lapiplasty will then stabilize this bone and reduce the amount of stress that makes it to these bones. So it's certainly not a contraindication or prevent you from having that procedure done.
Okay. All right. Well, to be respectful of your time, I think we'll begin to wrap up. To everyone that attended, if your question did not get answered or you think of something later that you wish you would have asked, feel free to reach out to us. Our email address is patientinfo@trees.net, or you can simply reply to one of the emails you received in terms of when you registered for the event. You can learn more and find a locally trained doctor by visiting the patient website, alignmytoe.com. And as a follow-up to this evening's presentation, we will be emailing all registrants an archived webinar link for reference, so be on the lookout for that from us. We hope you found the information presented tonight helpful, and we appreciate you joining us. We hope you have a very nice evening.
Thank you, everybody.